Good evening, everyone. Today I want to talk to you about a significant development in international health partnerships that signals a fundamental shift in how American foreign aid will work in the decades to come. The United States has just signed new health assistance agreements with Kenya and Rwanda, and what makes these deals unprecedented is not just what they promise to deliver, but how they're structured to change the entire relationship between donor and recipient nations. Let me start by giving you the context. For years, the United States has been the world's largest provider of health assistance to African nations, spending billions of dollars annually on programs fighting HIV and AIDS, malaria, tuberculosis, and maternal and child health. The President's Emergency Plan for AIDS Relief, known as PEPFAR, alone has invested over $90 billion since 2003. But there's been a growing recognition in Washington, and frankly in many African capitals as well, that this model of indefinite aid dependency isn't sustainable and doesn't serve the long-term interests of either party. So what exactly are these new deals about? At their core, they represent a transition from what we might call perpetual assistance to planned partnership. The agreements lay out a roadmap where American financial support will gradually decrease over a period of years, while Kenya and Rwanda simultaneously increase their own domestic health spending. This isn't about America pulling out overnight. It's about creating a glide path towards self-sufficiency that both sides have agreed to in advance. Now, let me break down the financial mechanics here, because they're quite ingenious. The deals establish what are called co-financing requirements. In the first few years, the United States might cover, say, 70% of certain program costs while the partner country covers 30%. But each year, that ratio shifts. By year 5, it might be 50-50. By year 10, the partner country could be covering 70% while American support drops to 30%. The ultimate goal is for these nations to fully fund their own health systems within 12 to 15 years. Kenya and Rwanda weren't chosen randomly for this pilot program. Both countries have shown impressive economic growth over the past decade. Kenya's economy has been expanding at around 5 to 6% annually, while Rwanda has seen even more dramatic growth, sometimes exceeding 8%. Both have demonstrated genuine commitment to health system development. Rwanda, in particular, has become something of a model in Africa for its universal health coverage system and its use of technology in healthcare delivery, including the use of drones to deliver blood supplies to rural areas. The specific health programs covered under these agreements span several critical areas. HIV treatment and prevention remain central, as both countries have substantial populations living with HIV. In Kenya, this affects roughly 1.4 million people. The agreements ensure continued access to antiretroviral therapy, but with an increasing share of costs borne by national budgets. Malaria control is another major component, particularly in Kenya where the disease remains a leading cause of death among children. Maternal and child health services, immunization programs, and health system strengthening initiatives round out the package. What makes this approach different from traditional aid is the emphasis on institutional capacity building. The agreements include provisions for training health workers, strengthening supply chain management, improving health information systems, and building domestic pharmaceutical manufacturing capacity. The idea is that by the time American funding phases down, these countries won't just have money, they'll have the infrastructure and expertise to use it effectively. Now, let's talk about what could go right with this model. In the best-case scenario, we're looking at a transformation of the aid paradigm that could be replicated across Africa and beyond. If Kenya and Rwanda successfully transition to self-funded health systems while maintaining or improving health outcomes, it proves that sustainable development is achievable. These countries would gain true sovereignty over their health policies, free from the conditions and restrictions that often come with foreign aid. They could make decisions based purely on their own priorities and circumstances. From America's perspective, successful implementation would mean that scarce aid dollars could be redirected to countries in more desperate circumstances or to new global health challenges as they emerge. There's also a strategic dimension here. Countries that achieve health security and economic stability become better trading partners and more reliable allies. The relationship shifts from patron and client to genuine partnership between equals. Consider the broader economic effects. As these governments increase health spending, they'll need to mobilize domestic resources more effectively. This could drive improvements in tax collection, reduction in corruption, and more efficient government spending across the board. The health sector could become an engine for broader economic development. We've seen this pattern before. South Korea and Taiwan both went through similar transitions in earlier decades, moving from aid recipients to aid donors. But I don't want to paint an unrealistically rosy picture. There are very real risks and challenges that could derail this entire initiative. Let's start with the most obvious one: economic volatility. Both Kenya and Rwanda remain vulnerable to external shocks. A global recession, a spike in oil prices, a collapse in commodity markets, or another pandemic could crater their economies and make the planned increases in health spending impossible. What happens then? Does America step back in with emergency funding, potentially undermining the whole premise of the transition? Or do health services collapse, leading to preventable deaths and a reversal of decades of progress? Political instability represents another serious threat. Rwanda, while economically successful, faces questions about democratic governance and political succession. Kenya has experienced ethnic violence around elections in the past. A political crisis in either country could see health budgets slashed as governments prioritize security or as corruption increases. The transition timelines in these agreements assume political continuity and commitment that may not materialize. There's also the challenge of what economists call the middle-income trap. As countries develop, they often find that continued progress becomes harder. The easy gains have been made, and further improvements require more sophisticated and expensive interventions. Kenya and Rwanda might find that just as American support decreases, their health challenges become more complex and costly. They'll be dealing with both traditional infectious diseases and rising rates of non-communicable diseases like diabetes and heart disease. That's an expensive double burden. I'm also concerned about potential gaps in the transition. The American health assistance infrastructure in these countries is vast and complex. It's not just money, it's technical expertise, supply chain relationships, international partnerships, and institutional knowledge. Can that really be transferred effectively within a 10 or 15-year timeframe? There's a risk of a hollow transfer, where funding responsibility shifts but the capacity to use that funding effectively doesn't keep pace. Let me address some of the political dimensions of this, because they matter enormously. In the United States, there's been growing skepticism about foreign aid spending, particularly among certain political constituencies. Some will see these deals as America finally getting smart about aid, insisting that other countries step up. Others will view them as abandoning vulnerable populations and breaking long-standing commitments. The sustainability of these agreements depends partly on domestic American politics remaining supportive through multiple election cycles. In Kenya and Rwanda, the politics are equally complex. These agreements require governments to commit future budgets to health spending, potentially crowding out other priorities. Political opponents could campaign against these deals, arguing that foreign powers are dictating domestic budget priorities. There could be public resistance to any service reductions during the transition period. African civil society organizations have already expressed concerns that this model might be a cover for aid cuts without genuine planning for sustainability. The reaction from other stakeholders in global health will be telling. Organizations like the Global Fund to Fight AIDS, Tuberculosis and Malaria, and Gavi, the Vaccine Alliance, have their own transition frameworks. How do the bilateral American agreements coordinate with these multilateral efforts? Is there a risk of conflicting requirements or gaps where countries fall between different systems? The World Health Organization has been advocating for domestic resource mobilization for health, so they'll likely support the broad approach while watching implementation carefully. Let's consider what this means for the broader architecture of global health assistance. If this model succeeds, we could see it rolled out to perhaps a dozen other countries within 5 years. Ethiopia, Tanzania, Uganda, Ghana, and Nigeria all have sufficient economic capacity that similar agreements might be feasible. That would represent a fundamental restructuring of American health aid in Africa. The United States Agency for International Development and PEPFAR would shift from being implementers to being transition managers and technical advisors. But here's a scenario that keeps me up at night. What if this becomes a template not for planned, gradual transitions but for abrupt aid cuts? What if future administrations point to these agreements and say, "We've given these countries a roadmap, now they're on their own," and then slash funding faster than planned? The difference between a managed transition and abandonment could be the difference between success and humanitarian catastrophe. There's also the question of what happens to populations that might fall through the cracks during transition. The agreements presumably have safeguards, but in practice, vulnerable groups like sex workers, people who inject drugs, refugees, and marginalized ethnic minorities often lose access to services during transitions. Civil society groups will need to be vigilant in monitoring whether the most vulnerable continue to receive care. From a technical standpoint, one key challenge will be pharmaceutical supply chains. Much of the HIV medication, for instance, currently comes through American-funded procurement systems that leverage massive economies of scale. As countries take over their own procurement, will they be able to negotiate similar prices? There's work happening to build regional procurement mechanisms and support domestic pharmaceutical manufacturing, but these take time to develop. Let me talk about the specific contexts of Kenya and Rwanda, because they're quite different and may face distinct challenges. Kenya has a larger, more complex economy, a more vibrant civil society, and a more contested political environment. The Kenyan government will need to navigate competing demands from a politically engaged population. Healthcare is just one priority among many, including education, infrastructure, and security. The Kenyan healthcare system is also more fragmented, with a large private sector and significant inequality in access between urban and rural areas. Rwanda presents a different picture. The government has demonstrated remarkable ability to implement centrally planned initiatives. The country has universal health insurance coverage, strong community health worker programs, and impressive health metrics given its income level. But Rwanda also has less fiscal space than Kenya and depends more heavily on aid as a proportion of its budget. The transition may require even more careful management of limited resources. Looking at the timeline, the first few years will be critical. Both countries will need to demonstrate their commitment by actually increasing health budgets as promised. There will need to be transparent monitoring mechanisms so that both American policymakers and African civil society can verify that commitments are being met. The agreements reportedly include specific benchmarks and triggers, where continued American support is conditional on meeting targets. I want to address the ethical dimensions of this approach, because they're important and contentious. On one hand, there's a strong ethical case for promoting self-sufficiency and respecting national sovereignty. Perpetual aid dependency can be demeaning and can undermine local initiative and accountability. If a country has the economic capacity to fund its own health system, there's something problematic about external actors maintaining control. On the other hand, health is a human right, and people living with HIV or at risk of malaria didn't choose their circumstances. Do we have an ethical obligation to maintain support regardless of these larger strategic considerations? I think the ethical answer is that transition is justified, but only if it's genuinely gradual, well-planned, and includes real safeguards to protect vulnerable populations. The test will be in the implementation. If we see health outcomes deteriorate, if people lose access to life-saving medication, if infant mortality starts rising, then we'll know the transition was mishandled. There are also implications for the private sector and philanthropy. The Gates Foundation, for instance, is a major player in global health and has invested heavily in both Kenya and Rwanda. How does their strategy align with these new agreements? There could be opportunities for innovative public-private partnerships where foundations and companies help bridge gaps during the transition. Or there could be tension if different actors are pulling in different directions. There are also implications for the private sector and philanthropy. The Gates Foundation, for instance, is a major player in global health and has invested heavily in both Kenya and Rwanda. How does their strategy align with these new agreements? There could be opportunities for innovative public-private partnerships where foundations and companies help bridge gaps during the transition. Or there could be tension if different actors are pulling in different directions. One aspect that hasn't received enough attention is the potential for South-South cooperation and knowledge sharing. If Rwanda successfully transitions and maintains its health gains, it could become a source of technical assistance for other African countries going through similar processes. We could see the development of an African-led community of practice around health financing transitions. That would be tremendously valuable and would represent a more fundamental shift in global power dynamics. The COVID-19 pandemic, which many of you lived through, taught us important lessons about health security and self-sufficiency. Countries that had invested in their own health infrastructure and domestic pharmaceutical capacity were better able to respond. Those dependent on external supply chains and support faced devastating shortages. In that light, these transition agreements make strategic sense. They're preparing countries to be more resilient in the face of future health emergencies. But the pandemic also showed us how quickly progress can be reversed. Years of gains in HIV treatment, malaria control, and routine immunization were set back during the pandemic. The transition agreements will need to include mechanisms for flexibility in the face of emergencies, ways to pause the reduction in support if major shocks occur. As we look ahead, I see several key indicators we should watch to evaluate whether this model is working. First, health outcome data. Our life expectancy, infant mortality, HIV suppression rates, and other key metrics holding steady or improving. Second, domestic health spending. Are Kenya and Rwanda actually increasing their budgets as promised, and are those increases reaching frontline services? Third, service coverage. Are people maintaining access to the services they need, particularly vulnerable populations? Fourth, institutional capacity. Are health systems strengthening their management, supply chains, and workforce? We should also watch for unintended consequences. Will the focus on these specific health programs lead to neglect of other health priorities? Will the pressure to increase health spending lead to cuts in other social sectors like education? Will there be a brain drain as health workers seek opportunities elsewhere if systems become stressed during transition? The broader geopolitical context matters too. China has been expanding its engagement in Africa, including in health. If American health assistance is perceived as declining, will that create space for other actors to step in? Would that be a problem? Not necessarily, if it means more resources for health, but it could complicate coordination and introduce different priorities and approaches. I want to be clear about what I think the most likely outcome is. I believe we'll see mixed results. The transitions will be messier than planned, with some backsliding and course corrections along the way. Some aspects will succeed while others struggle. Kenya and Rwanda probably will increase their domestic health financing, but not always as much or as quickly as scheduled. The United States probably will reduce its support, but will maintain some level of engagement indefinitely. Health outcomes will likely remain relatively stable, though with some disruptions during the transition. Neither the best-case scenario of triumphant self-sufficiency nor the worst-case scenario of collapse is most probable. But here's what makes this significant regardless of the specific outcomes. This represents the opening of a serious conversation about what sustainable development actually looks like. For decades, we've talked about building capacity and promoting ownership, but often in practice, aid relationships remained deeply hierarchical. These agreements, whatever their flaws, represent an attempt to operationalize partnership and transition in concrete terms with specific timelines and commitments. If I were advising policymakers in Nairobi or Kigali, I would emphasize several things. First, be realistic about fiscal space and don't make commitments you can't keep. It's better to negotiate a longer transition period than to agree to an unsustainable schedule. Second, invest heavily in revenue mobilization and public financial management. You'll need both more resources and better use of existing resources. Third, maintain strong relationships with civil society and make sure they're part of monitoring and accountability mechanisms. Fourth, plan for shocks. Build contingency reserves and flexibility into your health financing. If I were advising American policymakers, I would stress the importance of genuine flexibility and partnership. Don't treat the timelines as rigid requirements. Be prepared to adjust based on circumstances. Invest in robust monitoring and evaluation so you have real data about what's working. Maintain close consultation with implementing partners on the ground who understand local realities. And be prepared to defend this approach politically, because it will be criticized from multiple directions. For civil society organizations, your role will be crucial. You'll need to hold both governments accountable to their commitments while also advocating for protections for vulnerable populations. You'll need to monitor whether the promised financing materializes and whether it reaches intended beneficiaries. You'll need to document problems and successes so that learning can happen. As I wrap up, I want to return to the fundamental question these agreements raise. What does solidarity look like in an interconnected but unequal world? The old model of indefinite aid has provided crucial support but also perpetuated inequality and dependency. These new agreements attempt something different, a time-bound partnership aimed at building genuine capacity and self-sufficiency. Whether they succeed will depend on sustained commitment from all parties, flexibility in the face of challenges, and genuine concern for the well-being of the people these agreements are meant to serve. This is an experiment worth watching closely, because if it works, it could reshape development assistance across many sectors and countries. If it fails, it could undermine confidence in transition approaches and potentially harm millions of people. The stakes are high, the path is uncertain, but the conversation is essential. Thank you.